Good evening, everyone. So, the GEP profile or the gene expression profile is the center page of PTCL right now. Initially started with solid cancers and slowly moved into acute leukemias, then to the B-cell lymphomas, and now even T-cell lymphomas are all about gene expressions. So, last year alone, we had two major revisions for the classification and nomenclature changes. So, the WHO Heme5 and our international consensus classification of mature T-cell and NK cells. So what actually was changed? There are 28 entities in mature T-cell lymphomas, and we don't expect you to know everything. But when it comes to mature T cells, and my topic is nodal T follicular helper cell lymphomas and PTCL NOS. So what is the change? Initially, what was called as angioimmunoblastic T-cell lymphoma, follicular T-cell lymphoma, and PTCL NOS and nodal TFH type were classified as nodal TFH lymphoma of angioimmunoblastic type, follicular type, and not otherwise specified. And PTCL NOS was separated. So this was a change in WHO Heme5 classification, and the same applied with a slightly different nomenclature in the international consensus classification. So what are PTCLs? PTCLs are mature T-cell lymphomas or malignancies of post-thymic T cells. So these are 15 to 20% of aggressive lymphomas. But if you see, they contribute only 5 to 10% of NHL. So majority of these lymphomas are pretty aggressive. These are the percentage of pie chart of PTCLs. You see the major chunk again is what I'll be talking about. The PTCL NOS and the angioimmunoblastic type, which contributes to almost 40% of PTCL. And how have been the outcome of these PTCLs? With the exception of positive ALCL, almost every subtype has a very poor overall survival. The standard existing therapy, less than 50% 5-year OS in the largest series, that is the International T-cell Lymphoma Project and the BCCA series. What are the clinical features? This is essentially a disease of the older age group. Males are it's more common in males, and generalized lymphadenopathy and organomegaly are seen in almost all patients, and systemic symptoms in the form of arthralgia, arthritis, skin rashes are seen. And why so? We are all well aware that the autoimmune manifestations which we were previously attributing to B-cell immunology dysregulation has been changed. We are seeing this as a fault of T-cell immune dysregulation. So T-cell immune dysregulation is what is happening in your PTCLs, and that is exactly why you are having a cytokine storm and autoimmunity in these PTCLs. So this is manifested with as systemic symptoms, arthralgia, arthritis, hypereosinophilia, effusion. And because of this crippled B cells, we also have autoimmunity in the form of Coombs positive hemolytic anemia, raised globulins, autoantibodies, and extranodal involvement can be seen in liver, spleen, skin, and bone marrow. These are mainly seen in TFH subtype, where the B cell crippling is more common, or T cell dysregulation is more common. In PTCL, it is more common in middle than the very older age group of the TFH subtype. And hemophagocytosis is also more common in PTCL NOS. So what is the diagnosis and workup? The most important challenge when it comes to PTCL is establishing a diagnosis. I was talking about the International T-cell Lymphoma Project, which is the largest study, retrospective study we have on the data. There was only 75% concordance among hematopathologists in the diagnosis of any ALK-negative PTCL. So such is a concordance even among experienced hematopathologists. So arriving at the diagnosis is the first hurdle we have to be crossing. So as in every lymphoma, excisional biopsy is mandatory because this is a group of lymphoma where the cells which are causing the malignancy is very less. And the activated or the other immunoblasts and the other proliferating B cells are the major population of the tumor bulk. So you may not be actually seeing the pathologic cells in the microscope. So always excisional biopsy is what is recommended. Morphology, of course, can give a clue, but it's not always yielding. Immunohistochemistry is mandatory if resources permit. Of course, genetics in the form of TCR rearrangements, FISH for translocation, and a genomic profiling can be done and has become the basis of the recent classifications. and review by an experienced hematopathologist is mandatory. So we'll come to the first subtype. I'm going to be talking about two types, the nodal TFH and the PTCL NOS. The first subtype is the nodal TFH-cell lymphomas. So we have three lymphomas here, the angioimmunoblastic type, the follicular variant, and the not otherwise specified. So the first one, I don't know if you can really see, we see post-capillary high endothelial venules and the clear cells adjacent to that. So this is the pathognomonic histopathology of angioimmunoblastic T-cell lymphoma. So the majority of the tumor bulk or the lymph node is not made by the tumor cells. The tumor cells are just adjacent to these high endothelial venules with clear cytoplasm. You see that? So that is your angioimmunoblastic type. So next we come to the follicular variant, where the lymph node architecture on a low power scan is well maintained. You're going to see the follicles, but in between the follicles, again, you see these clear clusters of cells. These are your follicular cells or T follicular cells. And the inset shows the PD-1 immunohistochemistry expression of these cells. So this is a follicular type. So when they are making follicles, you call them follicular variant. When there are high endothelial venules proliferation with clear cells adjacent, you call it angioimmunoblastic type. When there are sheets of cells with no specific architectural pattern, you call them NOS. So these subtypes are particularly known to harbor very few malignant T cells and inefficient polymorphous tumor microenvironment, including immunoblasts. And this is exactly the reason why we are having so many systemic symptoms like hemolytic anemias, serositis, effusions, B symptoms, rash, hypereosinophilia. It's all because of the polymorphous tumor microenvironment. So that explains. So when do we call nodal TFH-cell lymphomas? It's based on the immunohistochemistry. So we need at least two of these T follicular helper cells markers, either PD-1, CXCL13, ICOS, BCL6 or CD10. If any of these two are present with the presence of CD4, we can call them TFH subtype. And if you see, and if you do an EBER in these tumors, 80% are positive. Why? Because of the T cell induced B cell crippling. That is exactly why you're having EBER positivity. So what are these? Again, shared immunophenotypic features by IHC. We already saw at least two of the TFH markers. And when we see the gene expression profile, so all the three share similar gene expression profile signature. What are the gene expression profile they are sharing? Epigenetic modifier genes. TET2, which is a myeloid malignancy gene, is seen in 50 to 80% of the cases. DNMT3A in 20 to 30%, and IDH2 in 25 to 45%. And if you see in myeloid malignancies, we know TET and IDH2 are mutually exclusive. But in these tumors, they can be present together. Why? I'll be showing you recently. So on top of an epigenetic modifier gene, you also have T cell signaling machinery gene defect. So you have the mutations of ROA, CD28, VAV1, PLCG1 as well. So we have these epigenetic modifiers and we have a lot of drugs targeting epigenetics. So can this be a poster child for personalized therapy? Yes. So we'll see if it is in the upcoming slides. So I was pretty impressed by this paper by Mora et al. In Pathogenesis 2016. What they said was, these are the mature, naive CD4 positive T cells. There are three profiles it can take. It can either be a T helper 1 profile, or it can either be a T helper 2 profile, or it can be taking a T follicular helper profile, what we are talking about currently. So with the expression of T follicular helper markers. So how did they have the epigenetic mutations? So these epigenetic mutations are present way up in your stem cells. So that is exactly why you can see them in the myeloid malignancies and also in the lymphoid malignancies. So these are your first hit. Just like your solid malignancies, we have two hits here as well. So these epigenetic modifications are giving a proliferation advantage to the stem cells. So when the second hit is that of the mutation which involves your myeloid markers, you have your AML, MDL, CMMLs. If it involves your lymphoid markers, you have your PTCLs. So in the form of either ROA or IDH2. So this is exactly why your IDH2 and TET2 can coexist in a T-cell lymphoma. So I found this paper very interesting. And this one as well, it was from the same paper, where we see in the clonal stem cells and clonal hematopoiesis, we have the TET2 and the DNMT3A. So with the acquirement of either ROA or IDH2, it becomes AITL. With the presence of RUNX or SR receptor or any myeloid mutation, it becomes AML. So just keep this at the back of the mind, because we are going into an area of targeted therapy and we'll be talking about it pretty soon. So we come to the second type we are going to be talking about, the PTCL NOS. Your follicular T helper cells markers are negative. Okay, so this is the most common mature T cell aggressive lymphoma. Up to 30% of your mature T cell lymphomas are your PTCL NOS. So they are a highly heterogeneous group of nodal lymphomas, and they can have a vast extranodal presentation as well. It's not that these don't harbor epigenetic mutations, these do as well, just that they have not been yet classified and they don't exhibit TFH markers. Morphologically, there is no specific pattern. So they are usually alpha beta deranged, CD3 positive, CD4 positive, CD8 negative, and they are CD30 positive in more than 50% of the cases, which I'm telling again and again just because we have a targeted therapy. So among CD30 positive lymphomas, we have our ALK positive ALCLs, which we are well aware of. It's pathognomonic, the CD30 expression. What are the other tumors? ALK negative ALCL, again, are CD30 positive. We have a cutaneous ALCL. We have our lymphomatoid papulosis, and one major chunk is our PTCL NOS. So it's a diagnosis of exclusion. So you have to do the TFH markers and your ALK to call it PTCL NOS. So now let's come into the gene expression profile of this, which is a change in the recent Heme 5 edition. So what they saw was that it's a GEP of all mature T cell lymphomas, and the red means the gene is expressed, green means the gene is not expressed. So they found three groups. There was a GATA3 mutated cohort, there was a TBX21 mutated cohort, and one was unclassifiable. So they analyzed the overall survival of these PTCL NOS. So they saw that patients with GATA3 mutated profile had a poor OS among this PTCL. And whereas that of TBX was not good, it was better than that of a GATA3 and an NOS. So this, if you remember previously, we saw that the mature naive T cells can have a T helper 1, T helper 2, or a TFH profile. So if T helper 2 is affected, that is your GATA group. So they have a downstream signaling pathway by the help of mTOR, MYC, and PI3K rearrangements. So again, these are targetable mutations and pathways. And you have the TBX21, which is the T helper 1 kind of pathway, which is mostly interferon and CD8 and NF kappa beta signatures. So we cannot be doing GEP on all our patients. So we also devised a immunohistochemical model where both GATA3 and TBX1 have an IHC marker, and it can still be done in all our labs. So GATA3 high group, it has more genomic complexity, worse prognosis with an enrichment of gene signatures associated with MYC, mTOR, PI3K, which we can target. Whereas TBX21 high subgroup, it has an interferon and NF kappa beta signature. They also have morphological patterns, which I don't think will fit within this talk. So even morphology can give a clue, and an IHC. So PTCL NOS we can classify as TBX1 or a GATA3 signature or a NOS. So a short talk on intestinal T cell lymphomas, because we are going to be treating it as the same as PTCL NOS or nodal TFH. So we have two aggressive T cell lymphomas of the GI tract, the enteropathy associated T cell lymphoma, the monomorphic epitheliotrophic intestinal T cell lymphoma. This is in the absence of an underlying celiac disease. This is with the presence of a celiac disease. There is no change in the management. Of course, you have indolent lymphoproliferative disorders as well. The main concern for us is that it should not be misdiagnosed. The indolent form should not be diagnosed as an aggressive form, and vice versa. So initial workup, what are we going to see? We are going to see the complete blood count. What do we expect to see? We can have cytopenias because of the bone marrow involvement. We can see hemolytic anemias. We can see Rulu formation because in angioimmunoblastic type of TFH, we saw that there is going to be hypergammaglobulinemia. And we can see eosinophilia, which is again seen with PTCLs. We need a comprehensive metabolic panel for any further therapy, LDH for prognostication, and HLH parameters, because PTCL NOS is widely associated with hemophagocytosis, and viral markers. Bone marrow aspirate and biopsy for full staging, as marrow involvement likely carries prognostic significance, and we want to counsel the patient because we know the outcome of these patients are pretty grim. Staging is by the Lugano modification of Ann Arbor staging system, PET-CT is recommended over CT, but PET-CT is not adequately sensitive to detecting bone marrow involvement. As we know, the tumor load of the neoplastic T cells is very less and it's going to be the B cells, so the PET-CT uptake is not good. So it's not recommended. If you want a complete staging, get a bone marrow done. So how do we stratify? The normal IPI, which we use in any other NHL, can fit T-cell lymphomas as well, but still there are modifications. Prognostic index for T-cell lymphoma, where we are more extranodal sites and stage 3 or 4 with bone marrow involvement. Okay, the patient doesn't want to get a marrow. We again can have a modified PIT score where we use Ki67 with the rest of the panels. And we have an international T-cell index, which used platelet count as an additional marker and T-cell score with incorporated albumin and a neutrophil count. Is anything better than the other? Not much, not significantly better, but they say T-cell score has a slight advantage. So what is the prognosis? I have been telling from the very beginning that the 5-year survival is less than 50%. So we see the data of the International T Lymphoma Project. It was 2011's 2000 till 2002's data. Less than 50% in all non-ALK positive PTCLs, which includes ALK negative ALCLs as well. So this is a Swedish registry till 2009. Again, less than 50% at 5 years. This is the Netherlands registry, which was published in 2022 Blood by Brink et al., which showed a slightly better outcome in non-ALK positive PTCLs. We'll be talking about why. So what was the therapy? Anthracycline-based therapy was the crux or the spine of therapy of PTCL. But what was it was pretty disappointing. It ranged from 20% in enteropathy-associated T-cell lymphoma to up to 56.5% in anaplastic large cell lymphoma. So we were not happy. So we wanted to add a fifth agent. So what was the first agent which was considered? Was etoposide. This study was by the German high-grade non-Hodgkin lymphoma study group, where they tried the addition of etoposide in all subsets of PTCL. And this was previously discussed, so I'm not going to go in depth. What did they find? For patients less than 60 years with normal LDH, etoposide improved 3-year event-free survival, not overall survival, event-free survival from 51 to 75.4. So patients with ALK negative ALCL, PTCLU or AITL presenting with IPA more than one have a poor prognosis and should be considered for novel treatment strategies, was what the conclusion they gave in 2010. So etoposide only helped 3 subgroups in this: ALK positive ALCL, patients with age group less than 60 and normal LDH, no one else. So improving upon CHOP persisted. So the most popular trial design was CHOP backbone and a novel agent. So they tried alemtuzumab, CD52, T-cell targeting, negative study, romidepsin, 3-year PFS, 39% negative study, bevacizumab, negative study, bortezomib, pralatrexate, everything was negative. So what are the works currently in progress is the addition of belinostat, pralatrexate and azacitidine. It's phase 1 ongoing and the CA of 75%. So what is the data we have about the fifth agent or the fourth agent? It is brentuximab vedotin with CHP. Did you wonder why oncovin was removed and brentuximab was added? It was because we know from Hodgkin's trial that the BV had very significant neuropathy. So we didn't want to have a cumulative neurotoxicity. So we removed oncovin. And this was the echelon 2. The eligibility criteria was age more than 18, CD30 expression more than 10%. So systemic ALCL and PTCL NOS, everything was taken, but 75% of these patients were anaplastic large cell lymphoma. So when we are interpreting or extrapolating it to PTCL, NOS and TFH, we should take it with a pinch of salt. So randomized was at 1:1, 226 on each side, and end of therapy PET-CT was done. So what was the outcome? So when you take all CD30 positive PTCLs, the 5-year PFS was 51% with BVCH and it was 43% with CHOP. So it showed a benefit naturally. And this benefit was more seen in anaplastic large cell lymphomas. So this is what I was talking about. 72% are systemic ALCLs. So how much was PTCL NOS? 2%. How much was angioimmunoblastic? 13%. Should we really extrapolate treatment of our TFH and PTCL NOS? Is a question. So if we see PFS, of course, benefited ALK positive ALCL more. AITL slightly more, but not really, if you see statistically. So then we tried adding ROCHOP, which I said previously was a negative study. This is a subset analysis of ROCHOP in PTCL. Patients with TFH lymphoma subgroup, they had a statistically significant PFS. So which kind of, explains why they will be, because they have the epigenetic modifications and romidepsin is an epigenetic modifier. So this is again oral azacitidine plus CHOP for PTCL, therapy naive PTCLs, which included our TFH subset, but also the other anaplastic large cell lymphoma, which are ALK negative and ALK positive. Very nice 2-year progression-free survival of 65%. So now we have found that the positivity is only seen in BVCHP in patients with PTCL, NOS, and TFH. We really don't know. We should extrapolate the data of Echelon to our PTCL, NOS, and TFH. So what is the role of transplant? We know nodal PTCLs have a very poor outcome with upfront therapies alone, and the survival is very grim. So consolidation in eligible patients is recommended or considered by NCCN. They have not given a clear-cut guidelines. I'll be talking why. And when do we do it? Chemosensitive relapse, if it comes, if we had not consolidated, even then, autologous transplant is not what is suggested. Allogenic transplant is suggested. So PTCL, NOS, or TFH at CR1, if the patient had a chemosensitive disease and is fit patient, consider for autologous transplant is the recommendation by NCCN, and in relapse refractory disease by ASCT-CT, it is allogenic transplant. So we have multiple clinical trials, but none of these are ours. So they never compared with transplant and without transplant. All these trials were including anaplastic large cell lymphoma, which is ALK positive as well, except this Demore et al., which we will be talking in detail. All of these had all the PTCLs, and all of them went into consolidative ASCT at CR1, and they did show OS benefit. Some of them did show, some of them did not show. So we really don't have our answers. So this was our Energy T01. This was the only trial where they excluded ALK positive ALCL, and so we can extrapolate some of the data. So what they did was all ALK positive ALCL were excluded, all PTCL NOS were taken, and 4 cycles of CHOIT was given. If the patient is in CR or at least PR, they went ahead with ASCT, and they concluded that dose-dense induction and high-dose therapy with autologous stem cell transplant should be considered a rational choice for the first-line treatment of transplant-eligible patients with PTCL. So I think we can confidently that in a patient with chemosensitive disease and fit for autologous transplant, go ahead with transplant. Same study. So these are the registry data. The recently published one is that of complete trial. Again, this was including the ALK positive as well, anaplastic large cell lymphoma.
Dr. Faheema, we have 5 minutes.
They showed an OS of 87.6 at 2 years. So this was a Brink et al.'s 2022 paper. In that, non-ALK positive PTCL without ASCT had a hazard ratio of 5.68. So that again favors the role of ASCT in PTCL, NOS, and all PTCLs. So what are the cautionary notes? There are no RCTs demonstrating consolidative auto ASCT that it improves outcome in PTCL. There is retrospective evidence for and against. There are few prospective trials with diverse subtype inclusion, and we have a trial which is called Transcript, which included all ALK negative, and they are randomizing 1:1 with transplant and without transplant. It's still recruiting, so we'll be expecting the data in the next 5 years. So the relapses remains high with CHOP like chemotherapy alone, and thus is considered in most subtypes. So what happened with the Echelon trial? Even there, what ALK positive ALCL patients in CR, they had a good PFS with consolidative RT even after giving BVCHP for ALK negative PTCL. So yes, there's a role for consolidative autologous transplant. So what about relapse refractory disease? I was planning to elaborate, don't have the time. So we have 4 drugs which are approved right now. Pralatrexate, which is a folate antagonist, brentuximab vedotin, which we have seen in detail, romidepsin and belinostat, both of which are HDAC inhibitors. All 4 are the newer drugs which are approved for relapse refractory PTCL right now. So epigenetic modifiers are our HDAC inhibitors and the Beautiful data, maybe with chalk, especially for T follicular helper type, which again insists that we should need a IHC for classification as TFH subtype of PTCL and antifolates. And we have the EZH2 inhibitors, which again works by epigenetic modification, again, which will work beautifully TFH subtype. And we have the JAK inhibitors because some of them can be JAK mutant as well. So where are we with cellular therapies? Checkpoint blockades had to work. They have PD-1 expression. We saw in the follicular TFH type, which had very strong PD-1 expression. But what we saw with nivolumab was they had hyperprogression with the use of nivolumab. Fortunately, with pembrolizumab, we have not seen it. So the first trial with nivolumab was put to an end. We have the trial with pembrolizumab, which is going on right now in the relapsed refractory setting. And we have, of course, our anti-CD47 do not eat me signals as well. CART, where are we at CART? We have the anti-CD7 and CD5 in relapsed TALL, which is used in some PTCL. But the only problem is that T-cell lymphodepletion and the resultant viral activation, because CD5 and 7 are seen in normal T-cells as well. So what is the escape route? There is something called TRBC1 targeted CAR. So in normal T cells, both TRBC1 and TRBC2 are expressed, but in the neoplastic T cells, only TRBC1 or 2, either are expressed. So this will be a very good potential target for the next CAR development. So these are all in baby level research right now. So these are the various targeted therapy where we can aim with the PD-1 blockade, which are magrolimab, which is a do not eat me signal, your ALK inhibitions in anaplastic large cell lymphomas, your epigenetic therapies with HDAC inhibitions, HMAs, and EZH2 inhibitors, our CARTs, JAK-STAT if at all it's mutant, and your PI3K inhibition, especially in our GATA3 mutant PTCL NOS. So this is the NCCN guideline for relapsed refractory PTCL. So what is the summary? Nodal PTCL in patients age less than 60, normal LDH, and also ALK positive ALCL, go ahead with trial. So BBCHP in CD30 positive PTCL, but really should be extrapolate, is up to you and about the financial status of the patient. Consolidated ASCT in chemosensitive diseases and fit for ASCT. Please consider, because otherwise we don't have much options left. And relapsed refractory PTCLs, we have pralatrexate, romidepsin, belinostat, and brentuximab vedotin. So since they are relapsing a lot, there's a lot of role on especially epigenetic modifiers. So let's see what the future has for us. Thank you.